great. Okay, so Alan has just turned on the recording here. And just briefly, it transpires years ago, before I actually knew Peet well, I actually lectured for his study group. I was invited by a study group under its name, and we had a terrific time on one of my trips back to South Africa. And I was at that stage quite overwhelmed with that young man's organization skills, the questions he asked me, the abilities, but I really didn't know who he was. And since then, I've grown to know him and to really appreciate what he's achieved in dentistry and in his lecturing and materials ability. The one beef I have with Peet is he went to the other university, and the other beef I have with him is they would always beat us in rugby. You know, his university, my university, which was called Tux and Wits, was probably more exciting in our rugby games than today's Georgia-Tennessee game. But so be it. I still love him very dearly, and I'm grateful for his contributions to our sciences. So I'll briefly read his bio, which is, of course, very impressive. And Peet is the director of the Studio for Endo and Restorative Dentistry and Dental Education in Johannesburg, South Africa. He's a postgraduate and faculty member of that other university called the University of Pretoria, where he's currently appointed as an extraordinary professor in the Department of Odontology, School of Dentistry, University of Pretoria. He's the president of the South African Endo and Aesthetic Dental Societies. He's a recognized author in endo and restorative literature. He has lectured extensively, both in South Africa and internationally. He has over 218 publications. Bobby, he's challenging you at this rate. To his credit, and co-authored a chapter in a new endo textbook published by Castellucci. In his limited spare time, he enjoys traveling to explore nature and fulfill his second passion, which is photography, which he does magnificently. Above all, he's an innovator. He runs an incredible study group in South Africa with an international following titled Nomads. And it's a joy and a pleasure for me to welcome Peet to our seminar. Peet, for your understanding, I don't know how much Alan Farber told you about this. Alan sends his apologies. He's in flight as we're talking, but we're recording this for him. The iADS, the International Association of Dental Specialists, is exactly what the name describes. It's an organization that some of us, headed by Alan, conceptualized a number of years ago as a specialty dental group to promote specialty dental skills, knowledge, and experiences. So that is who our attendants are. And with that, Peet, it's all yours.
Thank you, Colin. Let me just get my screen shared. Welcome to everyone. Just give me a second. My computer is hanging sometimes, so I need to share twice.
And you can hear how he sounds like I sound. Okay.
Again,
it came up for a second, Peet.
Okay.
And we're back to the main screen. Okay, I see it.
Now, okay. Can you see
went away?
Can you see my slides moving?
Yeah. Okay.
You can see that.
We can see it, and it's scrolling through.
Cool. Thank you. So welcome to all the iADS members and giving up your time to listen to me this morning. I want to thank my friend Colin for a kind introduction, and we really had a good time when he visited South Africa again. And also to Alan that I collaborated with the last few months. I was supposed to give this presentation in April, but I lost a lot of information on my computer, and I had to actually prepare this lecture from start again. I present mostly endo programs and restorative programs, but this is one of my favorite programs, talking about photography, because that is my passion in life. I love photography on all fields: wildlife, portrait photography, dental photography, any photography. And then secondly, I cannot practice dentistry without magnification. That is just not possible anymore. In my mind, teeth are as big as you can see on the screen and not small little white pills inside a patient's mouth. I want to start with this quote from Jonathan Swift. He said, "Vision is the art of seeing what is invisible to others." And that is exactly the difference between a magnification dentist and a non-magnification dentist, is that the magnification dentist sees things and treats things to a different level compared to someone that does not use any magnification. Now, my journey started about 20 years ago, when my first microscope was a Zeiss Pico. I had a set of loops that I only actually used after I was microscope proficient. And today I'm sitting with quite a few Zeiss Zoomax microscopes in my practice, automated ones and manual ones. And then on the right-hand side of the slide, you can see some photography of a chamber, of an endo case that I love to do every day. I probably shoot in my practice probably about 80 photos a day. And every case is documented either by video or by photography. So if we talk about microscope magnification, these are the key benefits: magnification, illumination, documentation, communication, and ergonomics. And we'll talk more about that as we progress. Now, 87% of dentists has got eye fatigue at the end of the day when they work long hours. And this is according to Murphy in 1999. And then according to the Burton and Bridgman study, about 90% of dentists end up with some spectacle correction because of the eye strain of accommodating their eyes for fine focus over a long period of time in their career, if they've been practicing dentistry for 40 or 50 years. And then the other key thing that you're all familiar with is backache, more prevalent in females, although it's still a high figure for males as well. And this figure, interestingly, has moved up. This was a figure quoted about 5 to 7 years ago, and I'll show you some new data on that. Now, this is my practice, and you can see that I've got 2 microscopes now, and that's how serious I am about microscope dentistry, because my OMS 3200 is an automated microscope. And if I have to walk into my practice, and I've done that before, that something is not working on my microscope, then I have to close my practice for that day. So about a year ago, we installed a second, more manual microscope as a backup, so that I always have my magnification at hand. And what I'm doing currently with these 2 microscopes has made my life so much easier, because when I do restorative dentistry, I can leave my main microscope in focus on the patient's mouth, and then I can turn around and, for instance, trim my temporary restorations or adjust any laboratory work at the same time. And that's really made even a bigger difference in my life especially the last year and a half. Now, I'm going to switch between photography and magnification just to keep you interested and not just talk too much about magnification or too much about photography. And I'm sure that most of you are familiar with Glenn Krieger, and he said photography is the language of dentistry. And this is really something that I experience every day in my practice. I can't speak to patients without showing them visuals. The new generation of patients in our practices are all social media type of teenagers. They live for photos. They live for visual information. And I find that we can't communicate with these patients unless we show them a visual of what we're going to do, what is achieved, and what is the problems in their mouths. I want to take you back to the father of photography, and that's Ansel Adams. And he said, you don't take a photograph, you make it. And that's what we also want to talk about today, is how do you make good photos in your practice? Let's first ask the question, why clinical photography? Firstly, better case acceptance. Patients understand better. The key reason why I'm probably doing so much photography in my practice is not just for lecturing, but I've learned the most in my career from seeing my own work on a screen or on a video clip, and I'm learning from that. Every day of my life when I do a presentation, I see something that I actually could improve. And in my opinion, I've learned more from my own dentistry, improving myself, than what I've ever done at continuing education courses. And then generally, it's a better quality of care. It pushes you just to a new level. It helps you with diagnosis and treatment planning. And I think you all know how big that has become with DSD, for instance. It can act for legal documentation, forensic documentation, and then big patient education and communication factor in your practice. So what kind of photos do we take? We take intraoral, extraoral, lab products or materials we use. And then with DSD, we also moved into the portraits, and we can also use that for sharing these photos on social media. And it all depends on what you want to do with the photos. I use the photos for presentations. I use them for social media, for publications. I use them to collaborate with the laboratory, and I use them for communication with the patient. I think everyone that's listening today will probably agree that you might not be in the presentation mode. So you don't need very high-res images. I need them because I publish a lot and I do a lot of keynote presentations. So I agree that you probably don't need the same equipment at all levels, what I'm going to discuss today. But I think I'm going to aim my presentation at the highest level, and then you can decide where you want to fit in your kind of practice. If we talk about cameras, I'm unfortunately or fortunately a Nikon user. Lots of my friends in my group use Canon. I'm not very familiar with Canon, so I'm going to focus a little bit more on what I use. But in both groups, there is a full sensor, FX sensor, that's the same as film, the old film cameras, the film size, and then a DX sensor. So for many years, we all used the crop sensor, the DX sensor. It was slightly smaller. The key advantage of using a crop sensor is the fact that it magnifies your image. So if you use a 100mm lens, and for instance, on a Nikon, the crop factor is 1.5, it actually acts as a 150mm macro lens instead of 100mm. So you're getting closer. If you look at the image on the left-hand side, you can see that if I take a 100mm lens and I put it on a full sensor camera, it will give me the larger image. And if I put it on a DX crop sensor, it will give me a 1.5 crop, and it will look like I've taken the photo with a 150mm macro lens. Now, just to briefly talk about cameras, you can see on the top left the full frame size sensor. And then for many years when we started, we had APS-H, APS-C, and APS-H for C for Canon. Those are the cameras with the crop factor. And these are digital single lens reflex cameras, the top row. The middle row are more medium format cameras, like a small Sony, a Nikon handheld without the exchangeable lens, Olympus cameras. That is the range where we're looking at. So you can see the sensors are a lot smaller. And then we go down to more cheaper cameras. And at the bottom right, you can see the size of your cell phone camera's little CCD chip. Now, I'm just magnifying that a little bit, and you can see the mobile phone sensor on the right-hand side, the normal APS-H sensors in the middle, and a full sensor on the right-hand side. And you can also see some of the crop factors, although this might not be 100% correct anymore because things has changed since the slide was developed. But basically, it means that if we have a bigger sensor, more light comes in, and we can actually capture better pictures. We can capture a bigger range between light and dark colors. Less digital noise, so less grain. We just get overall a much better image. And if we want to crop that image maybe later on, we can crop it to probably 1/10 of the image size and still have good quality. So the point I want to make here is just you have to categorize yourself. If you're into lecturing, publications, you have to be on the right side of the screen. If you're just into patient communication, to the left side. But a key factor here as well is laboratory communication. Laboratory communication, unfortunately, pushes you more to the left of my screen as well. Just a simple example. Here is a little boy that I captured at a birthday party, and we used a medium, average, middle range camera on the left side and a high-end digital camera on the right-hand side. Now, it's not the same image, but just look at his eyes, and you can clearly see the difference. I can probably magnify the photo on the right-hand side to a billboard size, and it will still be clear. If I just magnify the photo on the left-hand side 10%, we will have digital noise or grain all over the picture. So this is just what you want to output at the end into your presentations or into your practice, or how you want to communicate with your patients. Here I've just blown up those two pictures on his eyes, and you can clearly see that the picture on the top is much more fuzzy and grainy compared to the image on the bottom. The reason I'm showing you this is just to talk a little bit about cell phone photography in your practice, because there's lots of new flash systems and LED lights developed for this. For instance, Smileline has got a very good system on the left side, Coco Lux, STL, and these things all cost money. And trust me, I've invested in all of them. I've put them down. I don't touch them anymore. The quality is just not predictable. Specifically, what they advocate on this slide is shade taking. Now, let me give you a few examples. And firstly, it's unpredictable quality. Sometimes the color change. Here you can see the same patient, but the upper arch looks different from the lower arch. There you can see another photo captured 5 minutes later, different colors. Here I capture it with a little bit change in the light and the flash system, and suddenly the teeth are bright white. And that is a normal digital SLR photograph. Not the best, but you can clearly see already the difference. It's more natural looking. I can see more detail on the teeth. I can see more detail on the gingiva. I can see more depth of field as well. If I look from the centrals to the molars, I can set the camera to capture all that details in much more exact parameters compared to the cell phone. So that's why I don't like cell phone photography. But just for plain patient communication, I think it is a useful tool in your practice. And I do accept that everyone here and in practicing dentistry is on a different level. But there you can see the difference. The top is a cell phone, the bottom is a very average digital SLR camera, and you can clearly see the difference. And the patient's mouth is better reflected on the bottom image. That's the color of the teeth and not the top image. Then we can move on. We can use more expensive flash systems, more expensive cameras, and you can see on this slide, I've captured the same patient now, but there's a lot more detail on these teeth. We start to see nuances, little transparent spots on that central. I hope you can see my pointer. We can see small cracks. We can see pericymata. We can see more texture and stippling on the gingiva. And I will show you how to capture that as well later on. But it's a much more detailed image if I have to send this to my technician, for instance, compared to the previous image. So I'm obviously favoring digital SLR cameras because it's amazing quality. There's no viewfinder parallax that you can make a mistake. There's no shutter lag. It's immediately when you press the button. You get excellent viewfinder information. If you go more into photography, you can look at the histogram. You can put a macro lens on here. You can put different flashes on. You can use off-camera flash and on-camera flash. Now, I don't just do, as I said, dental photography. These are my lenses I use for wildlife photography. And if you don't find me in my practice, you will find me in the bush somewhere photographing animals. And my favorite place in the world is Botswana, very close, next door to South Africa. Amazing game viewing off-road as well in this area. And my favorite animal to actually watch and capture on photo or video is a leopard. I can sit hours and hours watching these animals in the bush. So at the same time today with digital single lens reflex cameras, there's a built-in video camera that is as good as the best video cameras in the world. Here's an image that I captured while flying over the Okavango Delta in Botswana. It's a lechwe antelope that's running over the Okavango. Here's a fish eagle busy taking off. And you can see that I'm having a lot of fun. The last photo I'm going to show you in this section is hippopotamus, two hippopotamus, but the one is clearly in the main view of this photograph, just having fun in this dam. So we talked a little bit in the beginning about mirrorless. I haven't got a lot of experience with it, but about a year ago, I bought a Z6 camera, and then I made a big mistake. I bought a Z7 camera as well, and I really battled with these cameras. I do once a month, I do a photograph a dog show. We've got schnauzers, and I photographed the dog walk, and there's a lot of action involved. And I really struggled with these cameras to capture those images. In the practice, they're not bad, but they weren't as good as my conventional digital SLRs. And I was really struggling with them. At this stage, I've actually mounted one on my microscope, and one is now on my webcam, so it's become a webcam. So I'm very disappointed in this technology. I've recently, about 3 months ago, acquired the top Nikon Z9 mirrorless camera, and that is an amazing camera. But that is not for, I will never recommend this just for dental photography. You have to do a lot of other things to justify the price of this body. This body is going for about, I think in dollars, probably about $5,000 US. But it is an amazing mirrorless camera, and I'll show you some images in a moment. The other problem with the Z6 and 7 is that if you want to use a conventional lens, like if you have a macro lens in your practice, you have to have a converter, and that converter slowed everything down even more. We can now buy a macro lens, a Z macro lens, that fits directly on these cameras with amazing speed. However, with the Z9, you can mount conventional lenses and still have excellent functionality. Here's an image that I captured of my schnauzer. His name is Max. And I think I don't know, we probably lose a lot of quality through Zoom, but if you look from his nose up to his eye, the amount of detail that we captured here is really amazing. This is a photograph of my 5-year-old called Kana. And if you blow this photograph up on a big screen, the detail captured here is just phenomenal. And coming back to dentistry, here's an image that I shot recently at the course with the Z9 and 100mm macro lens. And you can clearly see the detail on this patient's lips, the teeth, the translucency, the starting to see stippling. We didn't go for that in this case exactly, but I think you can agree that this is really an amazing image coming from this Z9 Nikon camera. Let me share with you a case. This patient, 20-year-old female, she had some trauma. She fractured two centrals, central and a lateral. There's a pulp exposure there. She arrived at the practice with these two teeth fractured, and you can clearly see on the lateral we've got 3 fracture stress lines running at the neck of that tooth as well. She luckily had the fragments, but the fragment for the lateral was actually shattered. I don't have a photo of it, but if you look on the palatal side, it was in pieces. So I decided not to bond that back. I decided to bond back the central, but we had to do a SWEC pulpotomy here, intentionally going into the pulp so that it allows me to pack MTA for apexogenesis. So I packed MTA, covered it up with a little bit of Theracal, and then I bonded the 2 fragments together. And these images here, you can clearly see that I captured on my Z7 camera mounted onto my Zoomax microscope. And that was our final result. You can see the gingiva still irritated by the rubber dam placement. It's not our final polishing, but look at the tips of these teeth. Look at the fragment that I bonded back here. And that is one of the key things, and we must maybe not a good time to start this discussion, but Ed McLaren, that you're all familiar with, is also of the opinion that one of the key things that Nikon can capture better than Canon cameras in dentistry is translucency. And I see a lot more translucency on my images compared to my Canon counterparts in my study group. But look at that, that's immediately bonded back, and that is a composite filling that I built it up there. But you can clearly see the translucency on this bonded fragment even, and also little hyper mineralized areas at the tip of that tooth. So if we talk about the dental operating microscope, we're talking basically about, let's first talk about the two benefits. Yes.
Peet, do you want to take a questions break?
Yes. Yeah, sure.
I mean, that stuff is stunning. It's not nice, it's stunning. Man,
Thank you.
I didn't know one human being is capable of that. Guys, anyone got any questions? And, you know, like Andy, you're a very detailed oriented prosthodontist. Anyone got any thoughts, questions, input?
Actually, I do. These look great. My question is, when you shoot these, are you shooting in an automatic mode? Because I found that sometimes the light reflecting will change the exposure, or in a manual situation.
Yes, I'm shooting most of my images in aperture priority.
Okay, because when I bleach or do something else, sometimes that throws everything off with the color changing.
We teach at our courses to shoot in manual because I've got two photographers that help me all the time at the courses, and they are pro shooting in manual. I shoot, all my images are in aperture priority, and I find that they more consistent because in manual you are controlling the shutter speed, the flash output, and the aperture. In aperture priority, I've at least got one of them more stable, and I find that my images are more consistent when I do that. They don't agree with me on that, but that's what I do.
Yeah, I found the manual is really sensitive, and I can't get a good exposure either.
But guys, if you want to ask questions, just unmute and stop me, okay? You don't have to go through Colin. You can just stop me, no problem.
And I've got one question. Will you be talking about how you relate the quality of this image to the lab and how the lab is set up to receive the image? Will you be talking about that?
Not really in this presentation. I went through, I can answer you quickly. We went through a lot of detail on that with, I can't remember the name of the guy. I think it's Matisse. In fact, my technician is this weekend, again at a course in Cape Town. Also someone speaking on a new system, how to capture the image, pull it back into Photoshop or into Lightroom, neutralizes the grays, take the color back. And I must admit that we went through extensive amount of time to correct this, and we're just not getting it right. We're getting the odd case. I'm starting to get off the opinion, and when these people lecture, they've got one or two cases that work beautifully. The rest, I don't think they're showing really what the value is. So at this stage, we are using my photography, and I'll talk about polarized photography later on. That we use a lot in the practice, but purely as a guideline for the technician, just to check. He's still seeing my patient, checking the final shade.
Great.
But I'll talk more about polarized photography that we use a lot later on. So these are the first two benefits, is magnification and illumination. And I'm just going to quickly talk about what is the difference between loop and microscope magnification, because that's quite important. Loop magnification is convergent magnification, where microscope magnification is parallel magnification. It's got infinity corrected optics, shadowless coaxial lighting LED, usually right on your working field, and low to high range of level, low to high range level of magnification that you can see. But this is an important slide, and I wanna stress this slide. Firstly, it provides the best quality of magnification in dentistry. If we look at microscope magnification, and you can see a global microscope that I also had for 12 years. It can range from 3 to 25 to 29 to 40 sometimes. And a very important point here is 4 times loop magnification is not the same as 4 times microscope magnification. There's a huge difference because the microscope gives you better image quality, better visual acuity, more detail, the depth of field and the illumination is very different. And people sometimes think they work with 4 times loop magnification and they think it's the same as working with the microscope. It is completely different. Just think about it. The lens of the microscope is 8 to 10 times larger compared to that of loops. So you must see a drastic difference in optical quality. There's a new loop system out from Brian Dental, refractive loops, that I will talk about later on as well. So let's first talk about the physical benefits. The first physical benefit is that it improves visual acuity. The benefit of magnification is basically to improve visual acuity if we talk about dentistry. If we look at this, class 2 occlusal palatal amalgam restoration, I'll focus on that for a moment. But let's first talk about what is the visual acuity of the human eye. The human eye's visual acuity is 200 microns. So if you have two lines apart 1 millimeter from each other, you can divide it into 5 blocks of 200 microns. And that's what you can see with excellent 20/20 vision. You can distinguish between 200 micron lines. If you bring those two lines closer than 200 micron, your eye picks it up as one space. So you can't see the difference anymore. And that's a problem in dentistry already when we cement crowns, for instance, because we are looking at some marginal fits now with digital CAD/CAM technology up to 35, 50, 70 microns. So you can't really assess the fit of that restoration if you can only see up to 200 microns. If we use 2.5 times loops, it pushes that 200 microns up to 80 microns. So that means you can now see not just the 200 micron difference, you can see all the red lines in between a millimeter line. So you can see 80 micron differences by just having 2.5 times loops. So you can imagine if we move this magnification to 8 times or 10 times or 15 times, that we don't really work under the microscope all the time. I would say I work most of the time for general restorative dentistry. I work about at 8 times microscope magnification. Here you can see my friend Glenn Van Ass in Canada. He wrote this article, and you can see the resolution. If you look at the third column, naked eye resolution is 200 microns. If we jump to 4 times loops, it's 50 microns. If we go to 10 times microscope magnification, 20 times micron resolution, and hardly ever we work under 20 times unless we remove a fractured instrument maybe, then you can go down to 10 micron resolution. But you can clearly see a lot more visual information compared to using your naked eye. Now, if we come back to this slide, lots of times when we work and we do examination, I would probably look in my mirror with my 20/20 vision and say OP amalgam, and we'll move on. But sometimes I bring the microscope in, and I'm probably now at the point that I use my microscope all the time for checkups as well, because then you bring your microscope and you look maybe at a tooth next door, and then suddenly my eye catches this amalgam. And just look at what we can actually see here under magnification. If we just increase it by 10 times, we can see 8 cracks in this tooth. We can see more distinct discoloration. We can see marginal leakage of the amalgam restoration. And this is a simple example, but this is what I see every day when I do microscope dentistry. Linus and Giesberger showed us that 50% less clinical and laboratory errors are made, even just with 2 times magnification. That's a huge number, 50% less errors. When I got my first microscope, I was amazed to see that I prepared a crown with 20/20 vision. Remember, I told you that I wasn't loop proficient in the beginning. I went from nothing to microscopes, and then I actually brought loops in for certain procedures in my practice. But this was a funny example one day. I prepped this crown and I was quite happy with it. The photo is magnified slightly already, but under 10 times magnification, this is how my margins looked, and I was quite shocked. And in my opinion, when I looked at this, when we cement a crown or fit a crown, we sometimes chip this enamel margins off, and then there's a defect, and that's where secondary caries come from. And I was horrified to see that this is the type of dentistry that I actually perform every day and think I'm really doing a good job. So today, our preparation margins can be done to a different level. Here you can see an anterior crown that I'm busy prepping, and you can see the precision that we can get when we're using just 8 to 10 times microscope magnification. I usually prep with coarse diamonds, fine diamonds, and then I will also go in with ultrasonic tip to do my final margin. But you can clearly see that that margin can be duplicated much easier for a technician, and we can get a much better fit compared to what I showed you before. So Spears told us long ago in 2018 already that smoother and more refined preparation margins, the better the crown adaptation will be and the longer the lifespan of the restoration. Here you can see a case that I've just taken a digital scan of, and I think you can agree that the technician will make a much better fitting restoration on these sharp margins. If we look at research, it shows you need at least 4.5 times magnification for proper vision and efficiency to create margins like these. And we are looking, as I mentioned before, the margin gaps for cementation thicknesses are coming down to probably 25 to 50 microns. And optimally, when we bring the patient back for cementation, this is the type of health we want to see when we remove our temporary restorations, because everything fits properly. I'm of the opinion that in certain cases, and I know I'm speaking to a lot of periodontists, but I'm of the opinion if we invade the biologic width to a certain degree with a good sealing restoration, I don't see any gingival inflammation. When we invade the biologic width with a poor fitting restoration, we see chaos. And I base that consumption also, or point, on the fact that when we look at the techniques by Didier Dici and Robert Sperifico and Pascal Magne, presenting margin elevation, where we go right into the biologic width and lift the margin. If we get an excellent seal there, we don't really see long-term gingival irritation. So here's my protocol, coarse diamonds, 4 times magnification. Then I will finish with ultrasonic tips under 8 times or 13 times magnification. And you can clearly see we're really producing very sharp, clean margins for our technician to produce an indirect restoration. If we look at this paper by Eichenberger, it's published in Operative Dentistry. They looked at the effect of magnification on the precision of tooth preparation in dentistry. And their conclusion was precision was significantly higher when a microscope was used, and followed by loops, and then the lowest precision was obtained when we don't use any magnification. This is also an interesting study that was published by Bauer in Journal of Endo, I think, magnification's effect on fine motor skills. And here they had a group of participants, 20 of them with microscopes 8 times, and 20 of them with loops 2.5 times. And they had a scoring system to evaluate what they did, preparations. I can't remember exactly what they did, but what the conclusion was that loops increased their accuracy with 17.5%, and the microscope with 57.7%. That's a drastic difference compared to unaided vision that they did their preparations with. One more study before we go clinical again. Visual acuity of dentists, and they took a little Snellen chart, excuse me, little Snellen chart, and put it in a class 2 box preparation. And they asked dentists to evaluate those little numbers. The first group had natural visual acuity, no magnification. They could have an average working distance of 300 millimeters fixed and an overhead light. And I asked them what numbers could they see. The second group, they had free natural visual acuity, no magnification, but they could choose their distance, because if we are older, we're sitting further away to see more detail. If we're closer, younger dentists will sit closer and you will see more detail. And then the third group, they gave them loops and additional light if it was available. And the focal distance was set at the loop and the overhead light. And they made very interesting conclusions. I'm not going to go through the whole study with you, but they made very interesting conclusions here. And they said magnification devices and the dentist's age have a significant influence on the visual acuity in the practice. What's the level of detail that we can observe? Dentists 40 years and older benefited the most of magnification devices. That's because of presbyopia. At about 40 years of age, we suddenly lose elasticity of our lens. We can't accommodate properly anymore, although we think we can, but then we can't focus on fine detail anymore. But though that group of dentists that identified that they benefited the most from the study to see those little Snellen numbers at the bottom of the class 2 cavity. The older the dentist, the more strong the recommendation was to use magnification in the practice to compensate for visual deficiencies. So that's visual acuity. The other thing it does, it increases field information. Now, field information is definition and also the number of picture elements per area, like a 2 megapixel camera versus a 40 megapixel camera, for instance. And also separation between colors. And that's quite important depending what type of dentistry you do. For instance, if we remove decay, it's critical to see a difference between hue, chroma, and value, because you can actually see where there's decayed tooth structure just observing it through the microscope in a way. And also for micro leakage or cracks or discoloration around restorations. Let me give you a simple example. Here's a building I photographed in Germany. And if you look at that top floor there, there's a little railing in front of that port entrance window there. Now, if I ask you to draw that fence in detail, every one of you will have some idea of what you're going to draw. But if I magnify that 10 times, and I show you the picture on the right, you will draw completely a different picture and deal with it differently if you have to fabricate that little railing, because you can see a lot more detail. And that's exactly what happens in dentistry. If we look in a patient's mouth when we're prepping a class 2 cavity versus having this magnified view, you can make better decisions. Should you be beveling the margin? Is there unsupported enamel? Is there still decalcification on the margin? Are you on dentine or on cementum already, or in enamel? What is your margin like? Can I bevel there, or am I going to take the last bit of supporting enamel that could maybe give us a better bond strength long term? So those are all decisions that we need this type of detail for. So the photo on the left has got 100 times less visual information compared to the photo on the right. Let me give you a simple example. This patient comes in for retreatment. I've got a rubber dam on. That's probably through the camera 3.5 times magnified. I can't see anything seriously wrong with it. And I've got an LED operating light. Now, most dentists operate probably without a rubber dam, a 20/20 vision that's maybe not even corrected, and a halogen operatory light. But when I brought my microscope in and I'm on my way retreating this tooth, then I realized that I'm seeing something different. I'm seeing a crack. There's a split tooth here under this crown. And that changes my whole treatment plan immediately. But if I only worked with the 1% information, I would have probably retreated this tooth, had a failure again, and just delayed the implant placement. And giving you more visual information, you make very different decisions when you treat the patients on all levels of all fields of dentistry, perio, endo, prosto, resto, orthodontics even. So Asad Mora, that you might also be familiar with, he was probably one of the first lecturers I learned from on magnification many years ago when Academy for Microscope Enhanced Dentistry was established. And he taught us that increasing the levels of magnification produce a squared and not a linear relationship to visual acuity. The photographs on the bottom shows a fractured file in the mesobuccal canal. Now look at the left side picture. You can get an idea there's something in the canal. And if I move to 8 times, you can clearly see now where the file is. And you can see where's dentine that I can maybe trough around to remove this instrument. But under 10 times magnification, I've got much better visual information to direct my ultrasonic tip of where to trough exactly to expose the head of this fractured instrument. And again, out of Glenn van As's article, you can see here the naked eye, our visual information is 1. If we have 4 times loops, the visual information becomes 16 times, and 10 times microscope magnification, 100 times more information. So you might ask, how much information do we need? I think sometimes maybe just 2 or 3 times more. We don't need 100 times or 400 times. We can't utilize that information, but it's very important to be in the category of 4 times, 9 times, maybe, to make good clinical judgments. if you look at the photo on the right-hand side, you can see a access cavity 3.5 times magnified. You can see just that you have a visual idea that I have a mesobuccal, distal buccal, a mesobuccal, mesolingual, and a distal canal orifice. If you look at the magnified view, you can see I have 3 mesial canals, a mid-mesial canal as well. And that is not possible to find, locate, and treat these anomalies in molars if we don't have good visual information. So it improves the ability to resolve between objects. If we use magnification, it gives us greater detail. Let me take you through a short video just of a clinical case where we removed the fractured file. This was one of our live cases we do at our diploma endo course. And you can see here I've got a 3D Zoomax microscope that we're using. And the students can see actually in 3D on my screens what is happening. So here we first created the platform for modified Gates-Lindenberg. And there you can see if I'm troughing, I can clearly see that I'm troughing around the file in precise detail and about 10 to 12 times magnification. This is the endosonora file on the ultrasonic scaler that I'm exposing the head of the file. Then the file fractured actually deeper, so we had to go in all over again. The file was probably overused from start when the dentist fractured it. And yeah, I've used some of the Yoshiteruyoshi tips as well to help me because I was now at a much deeper level. Not a fun exercise when 15 people is watching you in your own surgery and you break the file deeper off. Quite stressful. And yeah, I'm using the lasso technique with the Endo Cowboy from Korer Dental in Germany. Great device to have. Different thicknesses of loops, much more predictable. You can see my assistant is tightening the loop with tactile sensation on that ball bearing on top there. Clamping the loop around the fractured instrument. You can see how I'm moving it. And quite a good feeling when you remove that fractured instrument from the root canal system. But we need a lot of detail and a lot of visual acuity in the information when we remove these fractured instruments. And there you can see we gain patency to the canals again. So just to summarize that, 10 times gives you 100 times more information. And 20 times give you 400 times more information. Just for interest sake, I take a lot of photographs of eyes. It's quite we do this usually at the photography courses. And what we do is we take 2 soft boxes, put them in a triangle form, and then you come very close with the camera and you just photograph into the eye while the person looks straight ahead. And you can really get spectacular photos of eyes and see all the detail inside. There's that specific photo sharpened in Lightroom. You can clearly see, you can nearly see the rods and cones projecting there. Wow. So detail, it improves the resolution and field information. That is key. Let's talk for a moment just about getting older and what your visual acuity would be. So a person with normal vision, we're looking here at the near point, the closest distance, and you can all test that for yourself. If you take the tip of a pencil, for instance, or a pen, and you bring it close to your eye, what is the distance you can bring it close to your eye and still see sharp focus, or you can take a hair out of your skull as well. So the closest distance that an object can be brought to the eye and still have a sharp image of that produced on the retina, that is called your near point. And that will differ for all of us. And the older you get, the further the near point will actually move. And to obtain that sharp focus, your eye should be fully accommodated. So all the muscles will accommodate your focus on that point. And that's the problem. The older we get, the more strained our eyes are, the more difficult it is to do that. And we lose some elasticity of the lens. and then it becomes a problem. So for a normal eye, for a 30-year-old person, it should be about, you can bring that object as close as 11 centimeters and it will still be in focus. If you can't do that at the age of 30, you need some spectacle correction. Now, very quickly, I just want to show you this graph, and it's not accurate science, but it just shows you where you are on this graph. So if you're 20 years old or 22 years old, you still have to have your near point about between 8 and 12 centimeters, getting that object in sharp focus. If we move to 32 years, it will probably be 12.5, 13, around there. But here's the critical age. When we go past 40 and we maybe develop presbyopia, it becomes 25 centimeters that you actually have to have sharp focus. So what do we do as dentists? We're sitting further away from the patient to see perfect focus of the object. We can't, when you're young, you can actually put your head right into the patient's mouth to look at the upper wisdom tooth if you do a fissure sealant. When you're older, you can't do that because you have to maintain that 25 centimeter position to actually see the tooth in focus. And here's the scary part. When we get to 50, it becomes about 50 centimeters on average. At 60, it becomes 75. And at 70, it even goes worse. So the problem here is that when the near point exceeds the ideal working distance, then you start being uncomfortable in your practice and you start picking up musculoskeletal health disorders as well. And the classic thing I always teach young dentists is that when someone down the road, say 70 years old, do a filling, the filling looks brilliant to them. But when a young dentist looks at it and he's close 12.5 centimeters, he might say, who did this terrible job? But for the other person, it really looks like good dentistry. And as I mentioned, when we get older, my grandpa, for instance, puts his newspaper further away from him. That's the only way he can read. But he can still read, but he sees much less detail of the font, of how bold the text is. It's not the same level of detail. Now, let me give you a simple example, and I can show you millions of examples. But these are dentists that I accumulated work from that's in the 60 to 65 age category. And some of them are part of my study group. And I can see how their work is deteriorating if they're not using magnification. Look at this case. This poor patient went for a root canal treatment. Firstly, it ended up in a fractured file. That's maybe got nothing to do with visual acuity, but again, I think if it was done under a microscope, it might not have happened because they would have probably seen these two figure-8 shaped canal in there. The root canal was completed. It's short of working length. The restoration was left with decay. You can see that when I took the restoration out, there was a huge amount of decay and coronal leakage there, and there's no proper contact as well. But in this person's mind, I can assure you that this was a good level of dentistry. And that's what I often see as we get older, the level just deteriorates in a way. So let's move on from that and talk about documentation, because this is an amazing thing that happens with the microscope to document cases. So you've seen some of the videos of my practice already, real-time video of the microscope view on my monitors, or still photos. And one of the key things that I think base my relationship with my assistant on is the fact that she can actually see what I'm doing. When we walk in and there's something wrong with our TV screens in our practice, she's really grumpy for a whole day because she's got no idea what I'm actually doing in the patient's mouth. That is her lifeline. She can see, she preempts in a way what I'm going to do next because she can see the details. She's not just sitting next to me with a suction and thinking I'm in charge of the procedure. She's actually in charge. She can see the decay is out. She gives me the next instrument or the next material on. It's a key thing to build this relationship with your dental assistant on all fields of dentistry. I can capture pictures and videos during recording by just pressing a button. I probably go to the extent that I photograph a lot with an external digital SLR because the quality is just amazing. But I can, that case I showed you with the apexogenesis case where I pulp capped the procedure, that was taken off my microscope. and the quality is not bad at all. And except for that, I can record the procedure, I can show the patient later on, I can use it for lectures. Patients sitting in the surgery all observe what I'm actually doing. So documentation is amazing. By just pressing a button on while you're working, not picking up a camera even, you can achieve that. For a general practice, specialist practice, just having documentation, I think the microscope documentation is amazing. Communication. This is an interesting article that was written in a JAMA journal, Perils, Pitfalls, and Possibilities in Talking About Medical Risks. Now, I want to read this to you. The manner in which a doctor communicates information to a patient is as important as the information being communicated. Listen again, the manner in which a doctor communicates the information to a patient is as important as the information being communicated. Patients who understand their doctors are more likely to acknowledge health problems, understand their treatment options, modify their behavior accordingly, and I will probably add on to that. They will also much easier pay the bill for the work at a much higher fee because they understand what is wrong. By visually seeing the problems, they are more open to this type of communication. So here you can see my practice again. This screen is not my assistant screen. This screen is directed to visitors like parents or the husband of the patient. They are my best word of mouth clients. But when I walk out of my practice, they tell people what they saw on the screen. They've never seen dentistry like that. Doesn't matter if the dentistry is good or bad. They don't know what they're looking at. But to see visually what I'm doing on their child at that type of level of magnification, they just tell other people, and people want to come and experience this type of dentistry. The parents watch it in live, or the patient can also watch it in live. While we talk about that, I've got a screen right above the patient as well. But we hardly ever show patients the view unless they request it. I don't like it because they usually get bored, firstly. Secondly, when you bring in an irrigation needle like I'm doing there on the right-hand side, they sometimes move away because they think it's a needle. They don't realize it's just the irrigation needle. So they generally don't watch. I rather let them watch post-operatively if they want to see something, or communicate on WhatsApp with them with a bit of the video or showing them photos. But they generally watch general television with the TV above it, any program that they want. And then the last one is the important one. That's actually the reason why you should adopt microscope magnification, and that's because of ergonomics. Now, this is the biggest overlooked benefit of the microscope. Good ergonomics can increase your productivity by about 25%, according to studies. And dentists and auxiliary staff have a very high risk of developing musculoskeletal disorders. I'll share with you more detail on that. Studies show that approximately 72 to 80% of dentists suffer from work-related musculoskeletal disorder. This is a very high number. And 33% of dentists retire early because of musculoskeletal disorders. And this is the figure that was captured, I think, in Denise Murphy's textbook from dentists in the USA. I think it's actually now higher. I heard she's written a new textbook, but I haven't seen it. Here's the book. I don't know if you guys are familiar with it. It's a very interesting textbook. She talks about ergonomics in dentistry, stress in the practice, musculoskeletal health, low back disorders, how to optimize your working environment, the lighting in your practice. In fact, I think if you give this to a first-year dental student, you will probably quit dentistry immediately, because this is not a fun job to do for 20, 30 years in your practice, taking all these risks into account. This is a very old table from Denise Murphy's textbook, but just look at this. This is from dentists. Symptoms on their fingers, 46%. And then on the right-hand side is what percentage stopped working because of this. It's not high figures, but you don't want to be in that category. And then we can go hand, wrist, forearm. You can see shoulder, 51%. Neck and backache. Back is the big problem here. But that's not the main thing that you have to worry about. You might think my back is perfect. There's other diseases as well, because it's cumulative over the last 20 or 30 years that you sit incorrectly in your practice. But just look at backache. 60% of dentists, 8.8% stopped working early because of this problem. I'm not sure if I have the slides here, but Denise Murphy also talks about CTD, cumulative trauma disorders. And it's quite interesting if you go into that. They sometimes relate even cardiovascular disease, tendon diseases, all those things from sitting, say, incorrectly like this in your practice for 30 years. It's not just your back that's a problem. There's a lot of strain on all your body parts when you sit incorrectly in your practice. So if we work without loops, then, or any magnification, it has been shown that extending your neck like that for about 30 degrees forward, your chances of neck pain increase greatly, especially when it's done for extended period. And that's what you guys are doing. You're working for 10, 20, 30, 40 years in dentistry. 80% of dentists report neck pain over a 12-month period. And that becomes later on a chronic problem, and that can lead to early retirement. Look at your back when you sit like that. C-shaped spinal position, also causing a lot of debilitating problems like pain and joint problems. And 70% of dentists on average suffer eventually from back problems. If we just use loops, with loops, it means that your neck is more in a neutral position. Your declination angle is only 12 degrees that you look down into the patient's mouth. And that minimizes already all those consequences that we talked about. And look at your back. Your back is also in a better position compared to working without any loops. But look at the microscope. The microscope is amazing. It's the ultimate ergonomic design. It allows you to place your neck in an absolute neutral position. Your declination angle will be very close to 0. Sometimes, depending what you do, it might go to 20. But your neck is in a very comfortable, relaxed position all the time. And look at my back. My gown is now just pushed out a little bit there, but my back physically is in that position. It allows you in a completely neutral back position, encouraging ultimate ergonomic posture and preventing any back strain. And you can work for, at some stage, I work 13 hours a day. I don't do it anymore, but when I bought my new practice, I was working like crazy. I usually finished at 9, 10 o'clock at night. And I could sit for hours working like this without any problems. Just a mention on loops. I'm not going to talk a lot about it, but this is a new system. I'm not sure if you're familiar with it. It's called microscope loops. It's called refractives from Bryant Dental in the UK. And they basically design these loops that you can sit in a neutral declination angle and see in the patient's mouth. So it's very different from loops where you bend down with direct vision. So you actually look right in front of you, and at the same time, because of the refraction here, you look into the patient's mouth. And they actually have loops that are 7.2, 5.7, and 3.8, and they've just recently developed a 2.9 magnification as well. The other key advantage here is you see a lot more than conventional loops. If you look at, say, 3.8 times or 4 times loop, you just see 2 or 3 teeth. Here you see nearly the entire mouth, and it's quite a good system to use for periodontal surgery, because often you want to see more than just one specific tooth. You want to see the surrounding tissues. And I've only have about a month or 2 months experience with this in my practice, but it's really something to look at if you really decide you're not going to go to microscope view, because you're getting the benefit of neutral position, sitting correctly, and seeing a wider field of view, specifically if you do surgery where you're not working right in the access cavity, like, for instance, endodontic. So it's something to look at. I would suggest you Google this if you're in that position. But here you can see this guy sitting straight up, neutral position, but he's seeing up to 7.2 times magnification in the patient's mouth. Excellent illumination systems on it. And apparently in the next 2 months, they're going to launch a small camera. I'm not sure where it's going to attach, but you can take live photos of your operating field while you are actually using your loop system. That's going to revolutionize this type of dentistry. So let's talk a little bit about photos again. And I'm sure most of you want to take better photos. So the saying goes that your first 10,000 photographs are your worst. After that, it will get better. So don't give up your day job. And Ansel Adams, again, the father of photography, said 12 significant photographs in any year is a good crop. That's amazing. So don't think that every photo you're going to take is going to be perfect. It's a continuous learning curve in photography. So I told you already that my choice of camera is Nikon, but I've got nothing against it if you use Canon. But this is really my favorite camera, a Nikon D750. There was talk that it goes off the market and replaced it with a D850. This is really the best camera for me in dentistry. If I can choose today again, if I buy tomorrow, if I have to buy a camera, well, probably this is my first choice. It's not the most expensive camera, 24 megapixels, but amazing quality inside the patient's mouth. The dynamic range of this camera is also amazing. My photographer friends is experts in photographing cars. They've developed a system where they can photograph a car in any environment. Like they can walk into a museum and they can photograph a car and it looks like it's in a stereo. And this is the preference of camera of all the Nikon cameras on the market as well. So if you can get hold of one of these still, I would suggest that will be your best investment, in my opinion, compared to all the other Nikon cameras. And then a 105 macro lens. I'll just highlight a few things that I use. Canon has got a 100mm macro lens. The old Nikon macro lens is better for me because it's lighter. It's easier to manipulate in your practice. This one has got VR technology in, but they made it twice the weight. So it doesn't make sense to me. You're dealing with twice the weight, but you've got VR technology. So again, if I can choose, I would choose the old Nikon conventional macro lens. And then people are starting to favor this new Tonica 100mm lens. Apparently, very good lens, very sharp lens. I haven't got experience with it. The other lens I also use in my practice is the Sigma 105. That is just as sharp. Let's talk a little bit about flash photography. Because if you're going to photograph teeth, you need a flash to create 5,500 Kelvin light to reduplicate the structures exactly. So the first place we can start is a ring flash or twin flash, like you can see here. It's basically a ring flash, but it's broken into two different lights. Nikon doesn't make one anymore. That's a big problem. So you can't buy a Nikon ring flash anymore. You can buy a Canon one, I think, is also starting to move out of the market. This is a Mica one. Lots of different ones. Godox has just launched one as well that you can use. There you can see the Canon twin flash. That was the next generation. Nikon only sells this Nikon R1 C1 system that you can put 12 of those little flashes around the ring. But for dentistry, depending what practice you run, it's not ideal. I will share with you a few of my comments in a moment. So this is how it looks. It's got two little flashes and a commander unit. The big problem you can see already as you buy it from the shop, it's got a ring, and look where the two flashes are sitting. They're sitting very far away from the lens. So it works very well for smile photography. If you're doing a lot of anterior aesthetics, it's brilliant. If you go into the patient's mouth, you've got a problem because the light goes past the patient's face and you can't illuminate inside the patient's mouth. So then you're stuck suddenly. So you need another flash system. So be careful what you do. To solve this problem, lots of companies has got these brackets. Photomet has got one. This is from photomaster.com van Milos. And this is an L bracket that you can then mount these flashes on the bracket and move them closer, like you can see here, closer to the lens or further away. Again, it works brilliant for anterior smile photography. If you go inside the patient's mouth, you've got a problem. But you can clearly see here, this is a photo taken with the twin flashes. We can see lots of nuances here, calcification, hypercalcification areas, transparency, translucency, a much more pleasing photo than using a ring flash that will give you a flat view. If you want to move up from this type of photography, then you have to go soft boxes. If you have space in your practice for an additional room, then you need two soft boxes, and then you can get really exquisite photographs of smiles and front teeth in your practice. But you need space, you need time. It depends what you get for. A tip here that I want to share with you is if you're going to photograph gingiva and you want stippling and texture on it, you may have to dry it. You have to take a cotton bud or a tissue and dry the gingiva, and you'll pick up a lot more detail, and I'll show you some of the photos. Remember, we spoke about it right in the beginning of the lecture. From Dental Pro Master from Romania, you can buy these black retractors, and they are amazing to take these type of shots. Here you can see I've got a retractor on the one side and then a retractor on the other side. Now I'm shooting the side view into the retractor view. So it's going to create immediately for me a black background on the other side. So when I crop the photo, it actually looks like that. Now you can also see the stippling here, and that you will only pick up if you physically dry the gingiva with some blotting or tissue paper to pick that up. Otherwise, if it's covered by saliva, you won't see this type of detail. There's another example, and I think you can now see that the softer the light is, the more detail we pick up. Cracks, little crevices, translucency, stippling, staining of restorations. It just becomes a different world now, what you can pick up with this photography. Now, coming back to photographing posterior teeth, and like me, I'm photographing most of the time inside a pulp chamber. I want to photograph, for instance, the MB2 canal when I find it. Or I want to photograph the joint between a matrix system and my gingival margin. Then you need a small ring flash. And the best flash, in my opinion, is the one from Lester Dine in the US. Dinecorp.com is the website's name. Very small little flash. It's 7 centimeters in diameter. It sits right in front of your lens, and it fits on Nikon and Canon. And this flash is amazing for occlusal photography posterior or specific teeth. If you want to go photograph just the implant, for instance, that you've placed just in that socket, or my friend Rudy Garana does a lot of partial extraction therapy cases that we want to photograph the shield, for instance. That's what you need for these cases. Like, for instance, here you can see I'm photographing a premolar to show the patient there's a structural crack running towards the pulp. So I'm not going to do this with soft boxes and with all the other flash systems that I've showed you so far. Yeah, I've just prepared a mid-mesial canal on a lower molar. I want to be right in that pulp chamber and get this type of quality of detail. Other thing you can do as well, you can put a converter on, but it doesn't fit on all the lenses. You have to be very careful before you buy one, especially on the macro lenses. Like this converter fits on the new Nikon 105 macro, but not on the old one again. And I think on the new mirrorless lenses, it doesn't even fit. So before you invest in that, you need to check carefully that it actually does work. But that's another option to get closer into the patient's mouth. But you still need that Dinecorp flash to create enough light inside the tooth. Like here you can see, I'm looking for an MB2 canal. There's the dentinal shelf that you have to remove. My favorite instrument here is the endotracer burrs from Comet. And you can see I've just troughed between my MB1 and my palatal canal, and I can see there's debris left there. And that's why I'm going to go in with a smaller endotracer burr, deeper and deeper and deeper until I locate my MB2 canal, for instance. But if you're into this type of photography, you need, in my opinion, the Dinecorp flash. So let's talk a little bit about depth of field. Some of you might know a lot about it, some of you might not. In dentistry, we need wide depth of field. We generally want to see from the front tooth to the back tooth, or I want to see from the occlusal to the pulp floor. And in portrait photography, we also favor, again, narrow depth of field, where we want to blur the background. So it's two different fields that we're actually looking at. If you use a low depth of field in teeth, you're going to see like 2 or 3 or 4 teeth in focus, and the back teeth looks out of focus. And that looks terrible on a photograph. You want all the teeth in focus. So we're going to use a small aperture. Generally, courses teaches you to use a small aperture of f22, but I'm starting at best at 32. That's my starting number usually, f32. And then with some of the new digital bodies, you can go up to f64, in fact. But if I come to the left-hand side here with wide open apertures, then we're looking at more creative photography, not dental photography. So I want a teeth in focus from right to the front, right to the back. So my f-stop is going to be f32 to 64, aperture priority, as I mentioned before, with a macro lens and a flash system on top. If I photograph, for instance, my daughter Canna, I'm going to be f2.8 if I have the right lens on. Your macro lens, in fact, your macro lens, Canon or Nikon, is one of your best portrait lenses to photograph people with. f4 is a good number to start with. You have to focus very fine. Like here, we can decide, I will probably focus here, in this case, on a teeth to get a hair and everything still in focus. Because remember, your depth of field is 2/3 behind the point of focus and 1/3 in front. If you're at f4, you can play a little bit more with the depth of field. You won't be out of focus. But at f2.8, you have to be very careful because you might get a nose in focus and then the eyes might be out of focus again. Yeah, shot at f4. I was photographing kids at a school, and it's quite an interesting story. We did this week. I did it as a favor for Canna's class, and this I shot with my new Nikon Z9 and 100mm macro lens as a favor, just for an art project that they wanted to do in the class. 2 days later, I got a call from the school, Friday in fact, asking me if I don't want to photograph all the kids in the school. And because my focus was pin sharp and my background is blurred because I'm on f4, and I said, no, I'm actually a dentist. I'm not really a photographer. So let me show you a few more gadgets that you can buy into your practice. This is an amazing tool that I would suggest for every dentist. It's called Fix Light. Kalen Pop, the guru on Rubberdam, has developed it in Dubai. And this takes all the expensive flashes and stuff actually out of your practice and putting it right on your table, on your desk. So he's developed this system called Fix Light, where it's 2 soft boxes on a bracket, and you can put 2 of those Nikon flashes or Godox. In fact, I would recommend that you go Godox because there's so much stuff of Godox you can add on to the systems. If you buy the Nikon ones, you're stuck again if you want to have a off-camera flash for portraits. I go everything in my practice now at this stage, we're going Godox. So we put 2 Godox flashes on the side. Yeah, I just don't know the numbers, but if you can Google them, and then a commander unit or a flash trigger in Godox as well on your camera, Canon or Nikon, and you can swap it between the 2 as well. So you've got 2 soft boxes there. And it's aluminium bracket, the faster release if you want to take your camera off there, and it creates the most beautiful soft light view specifically for aesthetic dentistry. A little bit difficult to photograph in the back of the mouth. You can get side views, you can get occlusal views, but you're not going to get in photographing the pulp chamber with this type of light. And in any case, it's soft light, you're not going to see detail there. But for anterior aesthetic dentistry, this is an amazing gadget that you can buy. So you can order it online directly from Kalen Pop in Dubai. Really something I can recommend to you. Look at this. This is just a patient that just had bleaching. Pick up the Fix Light, take the shot. Look at the detail on these teeth. I know we lose a lot of quality with Zoom sometimes, but this is an amazing picture in my mind from photographing teeth for 20 years with lots of different systems. Just to pick up, look at these little detail of brushing marks or pericomata on these teeth that you can pick up. Here's the implant site where my friend Rudy has placed the implant. We did site development here, and look at that gingival tissue. Here's a upper arch that I've just finished in zirconia, and look at the texture on the crowns that my technician has actually developed. But for aesthetic dentistry, this is something that I would order when I move out of this lecture again and again. It's really the best thing that I've seen in the last 4 or 5 years in photography. Another cool tool that my friend Rudy, the periodontist, uses a lot is called Flash Cap. It's a diffuser that fits around your ring flash and it spreads the light evenly to reduce the harsh effect of the flashlight. Now, for a restorative dentist, I think this is useless. I've actually got two now. I bought one for a course. It didn't come in time, and then the developer gave me another one at a very good price. And in fact, I'm going to sell mine now. For restorative dentistry, I don't think there's an application. The only place I found an application for it is if you photograph metal posts in a patient's mouth, for instance, or something like it must be metal. In my opinion, now I've said to my study group, you have to photograph metal implants or you have to photograph blood. Any surgical field, it's an amazing tool for, and I'll show you some photos. This is Jesse Liu. You might know him. He's from Boston. He's a periodontist. These are his photos, and he's the developer of FlashCap. So if you're a periodontist, I think this is the way that you should go. You'll still have benefit from fixed light for final results if you're involved in the crown and bridge work. But for the surgery and for metal, this FlashCap is just amazing. But for restorative practices, I don't think you're going to benefit a lot from it. So it fits on different flash systems. Just make sure that you order it correctly. It fits on the Godox ring flash. That's probably the most cheapest ring flash that you can fit it on permanently in your practice. Just check when you order exactly. It tells you on the website which ones fits and which ones are not compatible. But make sure it's actually developed for Canon cameras. So when you have a Nikon, you have to be very careful and maybe text him and ask him exactly what you should order, or I can give you that information as well. Here's a MegaGen implant that my friend Rudy Garana's busy. There's two different cases, these, although they look like the same teeth, just flipped around. But I think you can appreciate what I'm trying to show you. For metal and red blood gingiva working fields, that flash cap is just stunning. With the fixed light that I've showed you before, you're going to lose a little bit more detail on the metal threads, for instance. But with the flash cap, it just keeps all the fine details being right there. So for surgery, I think the flash cap is an amazing device to have. So you probably want to take different photos, and we all know for a good photograph, you need to know where to stand, and that's what you need to learn in your practice as well. If you want to take, for instance, this type of photographs, photograph those blood vessels in that little frenulum, a little bit stippling on the teeth. This is not what I'm going to show to patients, but we use these a lot for social media and for also making, for instance, a big photograph in a practice. They make really stunning picture frames. Here we put a LED light in a patient's mouth, just a different type of photo. And then I want to talk about cross-polarization filters that you can use for what Colin asked about, shade taking and getting the shade of the teeth. This is what we're currently using on a basic level, just to give the technician a little bit more detail. So you buy a polarized filter that fits on your flash system. It has to be in front of your lens and on your flash. It becomes a little bit tedious to take it on and off. So I would suggest you buy a ring flash dedicated with this filter on. That's what I've got in my practice. Not to take it on and off. To take all these filters off and on again becomes so tedious that you're actually not doing it. So I've got a Godox ring flash. They're very affordable, and I bought one of these fixed filters, polarized filters that you put on there, and it stays there. So if I want to do polarized photography, I just pick that up and I go. I'm going to come back to you now with some more detail on that, I think. Let me show you one clinical example. This patient had 2 resin veneers that I placed 11 years ago. She was quite young at that stage, just came out of orthodontics. She had a root canal treatment on the 1-1. It had calcific metamorphosis. And this is now 11 years post-op. You can see that my teeth has grown a little bit more. My veneers are showing. The one is gray. She's a highly attractive young lady. She's doing modeling and she wants to fix this yellow central here. And you can see she's got very complex detail on the central incisor, the top left one that we have to copy if we're going to crown this tooth or veneer it. And I elected to actually just bleach that tooth. But look at what polarized photography can do for you. So you can either buy those systems from, I think we bought them from photomed.net, or you can buy this from Smileline. It's a very useful tool in my practice for composites as well. It's a Smile light, LED light at 5,500 Kelvin that you can just shine over the teeth to take shades, but you can also attach this polarized filter there. My experience is it works very well for about a year, and then you have to replace it. But it basically what the polarized filters do, it takes the specular reflection away on the surface, and I'll show you now. But a very useful tool for shade taking in your practice. If you put the polarized filter on and you're fitting a crown, for instance, you can immediately see if the value of the crown is off. Most of the time, the value is off and not the shade. So I would really recommend this Smileline light to you as a shade taking device, and also to introduce you into polarized photography. This is the one I bought recently, about a year ago, from dentalpromaster.com. You can buy their mica ring flash, also quite affordable, and then the filter fits permanently on there. So you don't have, if you have a twin flash system, you have to have filters on your flashes and on your lens. This one is all in one. It fits just in front of your flash, and it's right where your lens sits as well. So it works very, very well. But coming back to this case, here you can see the pre-op, and we were interested in the shades of those two teeth. You can see that I've bleached the central now with non-vital bleach already. And look at this. When you cross-polarize the photo, or take it with cross-polarization, you take the specular shiny reflection away on the surface. You can see better translucency. You can see the dentine shade. You can still see, this is the pre-op now before I bleached. You can see how the value differs between the two centrals, and you can see the gray appearance of those resin veneers quite nicely, and a lot of hypercalcification mottling on the central as well. So just doing a class 4 composite in your practice, it's already useful to have this information, to see basically detail inside the tooth. And it completely eliminates the glare, the specular reflection that I talked about, and it also enhances the contrast and the saturation. And if you pull this photo into iPhoto or Lightroom, you can actually move it around in contrast, and you can see a lot of detail. You can see exactly where there's mamelones, for instance, and where the dentine stops. So this is the information that my technician is after, not purely the shade. He will still take the shade himself. So you can also do it in black and white, and you can see the value differences. And in any case, so we treated this case, and there's the final of the case. You can see the laterals that I've done in Emax porcelain, and this patient was really ecstatic about a final outcome. The front central was just bleached, and you can see just different shots of her from different angles. So by the way, this is what we share on Instagram. These are the photos I'm giving her. I'm not going to give her, this I'll share with her, but I'm not going to give her a mugshot of her front 6 teeth to share with her friends. This is the photos I'm giving her that she shares. And this generates a lot of business in my practice when they put these type of photos on social media. You can see I like to cut their heads off. We call it headshots. Just focus on their teeth. It's not so important what, that's 3/4 of a head, but this type of photo. Generally, when the public sees these photos on someone's Instagram page, the first thing they ask is, who's your dentist? Where did you have it done? And we generate a lot of business with these type of photos. The other thing you can do with cross-polarization is also cut teeth in thin sections. This is just a hobby that I do as well. You cut the tooth down into a section of 0.5 millimeters, sandpaper it down, leave it in baby oil for about half an hour, and then you put a polarized filter at the bottom, the normal circular polarizers that you buy from a camera shop, one on your lens and one at the bottom with a flash from the bottom as well. And then you photograph these teeth. It's beautiful for waiting rooms or offices to do that. This is just a hobby. It's got nothing to do with dentistry, but if you're into photography, it's a nice exercise to do once a year and just get some nice photos. The other thing I do in the practice as well is micro photography. You can't do it in a patient's mouth, but if you have an interesting case or an implant that fails or something that you really want to photograph close up, You can look at this lens from Laowa. It's a 25mm f2.8. It goes to 5 times ultra macro compared to a 1:1 that we have with our macro lenses. And you can buy this macro flash with little soft boxes, and it's actually made for bug photography. You can buy it from landscape gear shops as well. That's actually where we bought it. And then you can photograph things like this, like really close-up views of a specific, like extracted tooth, and also make very, very nice photos. There's a decay lesion. Look at the detail that you can see in a decay. Yes, immature roots, a decalcification lesion, a crack through a tooth. Here I've done showing the benefit of using ultrasonics in restorative dentistry. You can actually see the enamel prism lines running here after we've used the diamond tip on this enamel surface. So this is more for creative photography and having fun in my practice. I think I will die if I have to walk in my practice every day and just do dentistry and walk out. This is my fun time when I have off to photograph extracted teeth or failed stuff and just see more detail of what we're looking at. So let's look at other stuff you can do if you want to be more creative in photographing teeth. The first thing you can look at, and these were mostly described by Miguel Ortiz, that you probably know as well in the States doing photography courses. And I'll just give you a few of these examples. You can photograph teeth with the silky smooth look. And here we're using obviously external bigger soft boxes. That if you make the light source bigger, the lights become softer. And as I said earlier, you have to have a specific room to do this in. But when you bring soft boxes in, you can start getting this type of detail, a very soft, silky, smooth look, depending on what you actually want to show. Yeah, I'm showing 2 front anterior crowns that I did for a patient a few years ago. Here's just some wear on teeth. Surgical sites also work well, but you don't want to really take a patient out. I will rather use the fixed light to photograph a surgical site like this. Then you can do diffusion just with a simple piece of white paper in your practice and a ring flash. Those of you that only have a ring flash, learn to take the ring flash off the camera. You don't have to have the ring flash on the camera. You can take the ring flash off the camera and just move it to the side of the patient's mouth. Sometimes you can get beautiful lip and teeth photography depending what you want to show. And if you want to diffuse the light and you don't have soft boxes in your practice, just put a normal A4 white paper in front of it and bring it close to the patient's face, and you have an immediate soft box. These were small photographs that we've taken with a ring flash and just a piece of A4 white paper. And you can see it really looks like it's been used with a big soft box in my practice, but it's just a piece of A4 paper. Another cool trick that I've learned from Style Italiano is to blow up a glove, a normal beige glove, and then you diffuse the light through the glove. So you put the glove on the patient's face on the one side, you ring flash against it, and then you photograph from the other side. I'll show you this video quickly. And I'll show you the photo. These are photos we've taken with the glove. So it acts as a little soft box. There's another photo. Really stunning photos that you can take with the diffused light. Chromaticity is when you move around the patient. Also more artistic photos. This is the same. This is a model we photographed in Germany at one of the courses. And by just moving, instead of keeping the flashlight right in front of a teeth, we just move sideways. And you can see how the color and the texture changes. So the chromaticity of the teeth change. Another technique you can use if you want to be more artistic is chiaroscuro. It's an Italian word meaning light and dark. It's more artistic technique, and also creating very dark and light shadows on teeth. So these are just examples of it. For instance, a cat in a hand, but looking at teeth, then you really make it more dark, and it just creates very unusual looking photos. Also nice for social media and things like that. Texture can also be photographed. Remember, I told you already about the gingiva that you can create stippling on if you dry it. Here we going after other types of texture, and again with flat soft light. You can see here very close image of two upper centrals. You can see a craze line there, little bit texture. Here I've done class 4 composites. This is my final polishing view. This is really amazing. I've got lots of these images where we just photograph the texture on teeth. This is how patients' teeth look. Sometimes with young patients, you can pick up the most beautiful texture on teeth. And that's what we're trying to simulate when we do composites. You learn a lot from this to create pericomata and the roughness on the surface when you do polishing. And then a few really silly photographs, but just to show you texture, close-up of a lip, puckered lips. Some of our courses, we do a lot of glamour photography. And you can see that it brings out beautiful texture on the lips. There's another case of stippling that we've just dried a gingiva. And if you just leave saliva on there, you won't pick that up. There's even a more closer up view. This is really a stunning photograph. One of the dentists at the course has actually made a mural out of this picture now recently that I've seen. And it really looks amazing in his reception. Right, so let's move on back to magnification for the last part of the presentation. And just I've given you quite a few examples already where I use the microscope, but assessing the fit of a definitive restoration. Remember, we talked about the micro gap. It's about 50 microns or less. So in average, articles recommend that you need to have 4 times magnification to distinguish between lines that are 50 microns apart. Here's a crown that I fitted a few years ago, zirconia crown, and you can clearly see 20/20 vision, it looks perfect. At 8.5 times magnification, you can see a discrepancy. At 13.6, sorry, the focus is not perfect here because it came through my microscope built-in camera, 13.6, and at 21.3, you can see completely a misfit. And when I was exposed to microscope dentistry, this was the biggest fights I've ever had in my career, is with my technician, because what they generally do is they put this crown on the stone model before we did 3D printing, and they polish the margin nice and smooth, but at the same time he's polishing the die. And when you bring it back at 20/20 vision, it looks like the crown fits. But when you look at it through microscope dentistry, the crown is actually short because it's over polished. And it took us a long time to get to a level. Eventually, you had to resort to a microscope as well. That's the only way we could solve this, because they make a lot of mistakes if they work just with 2.5 times loop magnification. Detect early pit and fissure caries. This is amazing. If you look at what David Clark taught us at the first microscope course many years ago, he said when you buy your first microscope, you've just done your last fissure sealant. And that's so true, because when you start magnifying these fissures and grooves and you start area braiding them, most of them becomes a preventive resin restoration because there's gunk inside those grooves. Look at this case. This is a occlusal that I photographed through the microscope. Let me give you one example of how I would do a fissure sealant. It's a very simple procedure, but if you put this picture on my screen, like if I examine this kid and the parents are there and I flash this photo on my screen, there's no debate anymore of what we're going to do here. They want to fix this. They understand why a fissure sealant is necessary. And they also understand why they're going to pay for the rubber dam, because we want to keep it dry. And they appreciate the quality of care that goes into these type of simple procedures, even in my practice. So here we're using aqua abrasion with aluminium oxide that we just clean those fissures out, or with bicarb soda. And that is the surface I captured through the microscope view. You can clearly see there's still a bit of debris. But another thing to get used to in microscope dentistry is where to stop. We can keep on cleaning the surface maybe another 30 times and get total elimination of these dark grooves. But you have to learn where to stop, because you can just carry on and on. But this is 500 times better surface to bond to, and a cleaner surface compared to the average fissure sealant that's done outside there. So we etch. And everything I do under rubber dam. And that's a key point I want to mention. I see a lot of people in South Africa buying microscopes, and then it becomes a white elephant for the simple reason that you can't keep focus if you don't have a rubber dam on. So that goes hand in hand for me. If you do microscope, restorative or endodontic dentistry, you need to have a rubber dam on because it keeps your focus stable of where you work. And there you can see the fissure sealant being placed after we place bonding agent and our final result. Few more examples. Remember I talked about class 2 cavities. How deep do you prep? If I look at 20/20 vision or even with 2.5 times loops, I can't see this amount of detail. Did I take all the decalcification away? Is there decalcification on my margin or in a box? Unsupported enamel. When I do class 2 composites, do I have to bevel? Yes, I have to bevel because this is how it looks. If I bond composite to that, I'm going to have marginal staining probably 6-7 months later. I need to remove that and bevel that margin. Matrix adaptation. I've got so many of these pictures. I love teaching on posterior composites. If you use a paludent system, for instance, or triodent system, and you assemble your ring and your matrix and your wedge, when you leave that in place for about a minute, it separates the two teeth. And what happens then is you have crevicular fluid moving in between your matrix and your gingival margin, as you can see here. So then you have to reevaluate your wedge placement or pack Teflon tape at the bottom because that crevicular fluid compromises your bond strength at your gingival margin. So this is what you need to see at high magnification. And again, these were captured with the DynCorp flash. You can't capture this type of image either through the microscope or with your DynCorp flash in an external mirror. So we've written 2 articles on innovations with magnification. These are very old articles, but basically we focused on all the steps for posterior composites. I will share with Colin a new article that we wrote that has just been published on microscope magnification that he can share with the group on WhatsApp. Few more examples. Enamel and dentine cracks. If this patient comes in for a root canal treatment and I show her a crack, she understands why, because she presented with irreversible pulpitis. If I work with 20/20 vision, I look at this photo. That's 3.5. That's 4 times magnified. I can get an idea there might be a crack here, but there, nothing. Here I show her the crack. She understands the consequence. She understands why she needs a root canal treatment. I can show her inside how far the crack actually penetrates. Is there a risk of placing a definitive restoration on this tooth? The communication is just very different when we have this type of views. Crack in sound teeth. I do a lot of these in my practice where I pick up pre-symptomatic cracks that we actually go and investigate. I'll just give you an example. This patient was symptomatic. We clean the surface, we stain it with methylene blue. If you see a crack that houses debris inside it, it is 95% a structural crack. You have to investigate it. If there's 2 craze lines on a margin, just craze lines, asymptomatic, if you open up there, you will find probably decalcification and early dentine caries, although the X-ray is quite clear. I don't want to speak too much about this, but just to give you an example on that case, it's a structural crack running through because it housed debris. Ying Yang Kim is David Clark's partner. I'm not sure if she still works there, but she said many years ago, the microscope is to cracks what radiographs are to decay. We pick up decay with radiographs, we pick up cracks with microscope magnification. And they wrote an article on this from David Clark and Cheryl Sheets, and they said to pick up these pre-symptomatic cracks, you need 14 to 18 times magnification. For instance, yeah, I took a leaking or just a defective amalgam restoration out, but the reason I did it is because of this. I saw 2 marginal craze lines under magnification. I open up there and I find early dentine caries there, although the X-ray is clear. So here's the article. It was authored by Clark, Cheryl Sheets, and Jen, I can't remember her name, Paquette. And they wrote it on definitive diagnosis of early dentine and enamel cracks. And I still use till today this article. So what they do is they give you guidelines of a type 1 crack. That might be one craze line on a marginal ridge or discoloration. Type 2 might be 2 cracks that you might have to investigate. And then type 3 is like a crack that houses debris, or a crack that deviates, or a craze line that deviates from the normal anatomy. Those you can go and investigate, and you'll see a structural crack inside. Very interesting article to actually read. As I do a lot of endo in my practice, I only use the microscope all the time for endo, and then also for apical microsurgery. I'll just show you a bit of this video clip. Here we're doing a apicectomy on a maxillary central, and this is all done under magnification. All the steps, the suturing, small micro mirrors. There you can see some necrotic tissue sitting in the apical part of the tooth. We're doing the retrograde with ultrasonic instruments. We're using methylene blue again to check for cracks. Very important step, because if there's a crack, the tooth will have to be extracted. So before I pack MTA and after my retrograde preparation, I check if there's not visible cracks stained by the methylene blue. And then we do our retrograde with an MTA-based type of material. So let me summarize. Magnification in your practice will improve your visual acuity and the information that you can see. It increases your precision. Remember the studies we looked at, it improves your fine motor skills and it improves your ergonomics, a very big factor, especially for a young dentist today. That is the number one reason why I would invest in microscope dentistry, not even because of all the other benefits we discussed in detail. It improves your clinical skills. You get better at stuff. You can faster reach a higher level of expertise when you can see better, have the right information all the time. It improves patient care. And then I love talking about this subject. I personally think that if a young dentist can adopt microscope dentistry, I think he will probably need 60% less training in his career, because whatever he's trained, he can actually do to a higher level. I see dentists sometimes at endodontic courses that comes back 3, 4, 5, 7 times to the same type of course. You ask them, why are you here again? You actually feel embarrassed to take their money. They say, I can't do what you do. And I say to them, it's simple. Do you have magnification? Do you have a microscope? No. So that's your problem. And when they adopt that type of level of care in their practice, they immediately move up into the ladder. Allow me 5-6 minutes to finish off the presentation. We're talking about portrait photography. Here we're going off camera flash, and one of the best tools that I've had the last 5 years of my practice is a Godox Light, the AD200, and you put a multifunctional softbox on your flash. Just to give you an idea, this is how big it is. It's very small. There's the AD200 flash, and it stands permanently in my office. And this is obviously now for taking portraits and also for taking smiles of the lips and close-up photos for my final social media photos. So you also get an AD300 now, that if you want a little bit stronger light, you can buy the AD300, but then you have to buy, I think it's a 65 S65 softbox. It's a little bit bigger, but the AD200 is an amazing flash for general photography as well. It's really something to look at. There's the AD300, and then you have to buy the Godox S85 S flash. A little bit stronger. The battery life on both these flashes are amazing. No power. You charge, I think I charge this flash probably once every 3 months for all the shots I can get from it on a daily basis. And then if you go really big and you have an extra room, you can look at a hexagon and an octabox, but that's really if you're big into photography. But most of the photos I'm going to show you now was taken with the AD200 flash off camera. And then you also need a trigger that we discussed to trigger this. And this is why I like the Godox system, because you can buy the AD200, you can have 2 flashes in your soft boxes, you can have a ring flash, and everything is geared from this trigger. So everything works together. You can have two twin flashes in your fixed light, and it's also working with the same trigger. So I would really advocate that you look at the Godox system as a whole if you're going big into photography. So this was a patient that we did some implants on, and these are the final photos. I know it shows nothing about the teeth, but this photo is more powerful to show on social media with her close-up photos than the dental photos. The patients or the people out there love these type of photos. Dental assistant we photographed at a course. This was a model. We did some photos at one of the courses. This was a patient that we actually did bleaching for. And just not photographing just the teeth, we gave her these to do portrait shots as well. And also created a lot of attraction to our practice to come back for bleaching from other patients. And then we do glamour and marketing photos. These are amazing for social media. They're a little bit over the top. You might laugh at them, but lots of dentists at the courses has also made them portraits in their reception or something. And you can't believe how many patients will actually ask, who's this person? Why, how did you get this right? Just normal glamour photos, incorporating fruit into these photos. That's just lip gloss. Yes, just the orange. It's just different type of photos and just having fun in dentistry as well. Going for aesthetic dentistry, these shots are quite useful as well. Instead of just photographing the teeth, I showed you examples before. It's just to photograph part of the face like that and showing the teeth. Very powerful on social media. I want to end off with this case, a little bit of dentistry, and then we are done, I promise, Colin. This is a young
Go on
patient.
forever, Peet.
Sorry, I couldn't hear, Colin.
I said, carry on. This is unbelievable.
Okay. It's the last case. This is a young boy. He's 9 years old, and he fell in a swimming pool, and he partially avulsed both these teeth. I don't want to show his photo of his face because I don't have permission of that for that, but it was really a horrific accident. And I see a lot of these cases in South Africa where the teeth are splintered, the maxillofacial splint them, and then everyone forgets to do the root canal treatment or follow up the teeth. And they usually land in my practice when there's resorption. And this is exactly what happened here. So you can clearly see that he's got external cervical resorption here. He's got a very open apex on the left central incisor. Let me just get my, yeah, that's the right, that's the left. I'm going to give you tooth numbers because I know you guys are numbering teeth differently and I don't know the numbers. But in any case, look how interesting this is. This tooth has got external cervical resorption, but look closely at the pulp chamber. Bone has grown right into the pulp chamber with a PDL. This is very rare. There's only one of these cases published in Andreasen's trauma textbook. So that tooth is quite compromised, but asymptomatic. We can't treat it, especially because of the bone moving in. The debate here is that tooth ankylosed or not, because it's got a PDL on the outside and a PDL on the inside. And probably some starting osseous repair of the resorption lesion on that side. But the symptoms at this stage is feeling uncomfortable on the left central incisor. It's got a wide open apex. You can see I've got a size 100 file in here, and it's only touching the one wall. So it's probably a size 300-400 canal size that we're dealing with. Very immature roots. And I want you to focus on this X-ray because I'm going to show you at the end the true thickness of these walls. In my mind, always, I thought that's thin, but not so thin. Okay. Just keep it in mind if you look at these X-rays. And so my treatment option for this tooth was revascularization. I wanted the root to form a little bit more or close by itself. At this stage, I can't do apexification because I'm not going to get an MTA plug in there. It's just going to go all the way out. And the second problem is I can't pack bone and then an MTA plug. But I thought revascularization would be a good choice in this case. So what we did is we decided to do the revascularization with PRF. So at the second visit after we placed calcium hydroxide, we had some PRF and we packed it down the canal. There's the PRF. packed it down the canal, put an MTA plug on top and sealed it. And if you look at this X-ray, you can see that we have a little bit thickening of the wall here. This is about 3 months post-op. And maybe a little bit of lengthening there, but then it stopped completely. The process just aborted. We see also here a spot of surface resorption starting there on the side there. And the case just didn't progress anymore. So I was quite worried about it. We left it another 3 months, and in that period, he developed more discomfort. So I brought the patient back, took a CBCT, and we saw a very large infection around that root. There's the CBCT. You can see a very large infection now, very immature roots. You can see the bone destruction there. That tooth is still stable. Look at the bone that grew in there with a PDL and the external cervical resorption lesion there. But look how immature these root tips are. There you can get an idea of how thin they are actually. And I was quite disappointed in this case because I was really hoping we're going to get some closure here. So then, taking into account his age and how long he's going to be without a tooth, I thought my next option would be to take him to theater and to clean out the lesion, pack some bone. My plan was to pack ethos in there and then to pack MTA against the ethos and clean out the lesion in one go. And I think our problem would be solved. And this is exactly what I've done. I walked into theater raising a flap, and luckily I refused to work. As I told you before, I can't even dread the fact that I can work without a microscope in my practice. When I go to theater, I need a microscope. And luckily that day, when I lift the flap, I saw a vertical root fracture. Now, I can guarantee you that now, that without the microscope, I would have carried on with the surgery. I would have packed bone, cleaned out the lesion, pack MTA, fill up the canal. As I lifted the flap, I saw through the microscope. That's the view. You can see it's not very clear, but it's there. And I had to extract the tooth. I had no option at that stage. And that's exactly why my case didn't work out with revascularization, because there was probably the fracture there from day one. And it was a fight against revascularization process to form a root tip, and the fact that we have bacterial infection on the side. So at the end, the bacterial infection probably won the race, and that's why my root development stopped. And there's the tooth extracted. These photos was taken with the fixed light. Now I want to show you something very interesting that I've never seen in my life. I just learned it in oral biology. So I came home with the tooth and I photographed it. We can probably assume that that is the follicle sitting around the tooth. There was the extraction site. I grafted that with ethos bone and we closed it up, and we're now in the debate of how we're going to treat this case. But then I stained it with methylene blue. You can clearly see the extent of the vertical root fracture. And then I dissolved that tissue with sodium hypochlorite. I started dissolving it, and I ended up with this more type of fibrous elastic tissue. So we can start debating about this. The oral biology department reckons that this is part of Hedwig's root sheath that we see here. And that's how revascularization works. We create a sterile environment inside the canal, and then we give Hedwig's root sheath the potential to actually start revascularizing the tooth. And then I dissolved more. And this was actually the beginning, in my opinion, of root formation. That is, it's not mineralized tissue, but it's an elastic type of tissue that formed in that first 3 months that we saw on the X-ray. There's another view of it. And there you can see it's actually cold. It's like plastic that you can see there. And there's another view, but look at the thinness of these immature roots. That really blew my mind to realize in real fact how thin these roots are. When we see them on X-ray, we think they're immature, but it's amazing how thin they are, and you can now realize why the tooth actually cracked vertically. There's a shot right into the edge, but this photograph blew my mind. It's paper thin. It's probably less than 1 millimeter thin in certain areas. And I think that gave me a very good visual perception long-term when I look at immature teeth in young patients' mouths and treat them, that I can actually realize what I'm actually dealing with. And imagine packing this open apex just with MTA. It's just not possible from just doing it from a retrograde point of view. There you can also get idea affinities with the crack. There's the crack. And then interesting enough, remember I showed you the one surface resorption spot. It could starting be also inflammatory resorption, but look at those two spots on the radiograph, and they were actually very visible on the root that I extracted, and that's probably cemental repair that we see on that surface. So with that, ladies and gentlemen, I thank you for your kind attention. I know it was a long session. I hope that I've enlightened you to take more photos in your practice, and also to maybe turn to magnification at an early age and enjoy dentistry for a little bit longer what you're supposed to. Thank you.
Peet, that was as stunning as the first time I saw your program. Firstly, for all of those on, I'm going to speak for a few moments. Please don't log off yet, because I need to give you the QR code, and we've got to change screens in order to do that. So please don't log off. I'll give you the QR code for those who want CE credits. But Peet, that was stunning. Just on this last case, that material, of course, is stunning. That's all I can say. But did you notice the periodontal destruction on that facial surface of the bone, which was probably associated soon after that traumatic event happened? And then, of course, we've got to ask, and I looked at the bone on either side in the CBCT, and there was decent bone there. So, you know, that wasn't big teeth in little jaws. My question to you before we open it up to the group is, you gave us an incredible amount of material. Do you have, or else you and I can collaborate privately, do you have a course that our American colleagues and probably international colleagues could participate in and attend for all of that equipment, all of those supplies, all of those product names, that I guess either, I don't know if you travel to the US, or alternatively that we could set up at least virtually so that people can start becoming comfortable with incorporating all of this technology into their daily routine practice. Obviously, you didn't become this proficient in a week or a month. This is a lifetime's worth of critical observation, trial, error, incorporation, rejection, etc. So firstly, an amazing program, as I told you after the first time I saw your material, and thank you for that, and the hours upon hours that it takes to put this together. So that's my first question. Then we'll open it up to the group. I know we've got in the attendance Steve Reimer, who's an avid photographer. He's an oral surgeon, also a Wits graduate, and he and his son organize high-end safaris to Southern Africa, avid material and a very, very close friend. So with that, my first question to you is, how can we get more information? And then I will be contacting you separately to get the bibliography, so at least I can get those articles and distribute it to those who attended.
The answer is simple, Colin. What we've learned through the years is we need to do a workshop in person with these colleagues. We usually run a workshop for 15 people. We run it over 2 or 3 days, usually 2 full days or 2 half days and a full day. And then we start from scratch. We go through all the flash systems, and we also teach the people how to use Lightroom. So for that, I need myself, and I need at least one photographer that's got more photography knowledge than I have, to share questions, to set cameras, whatever people bring to the course. So usually we are 2 people to run a course like that, and then we travel with some equipment. We generally do, for the last 3-4 years, we did a course at Dentsply Sirona in Constance for their OPLs. COVID has now stopped that a little bit, but that's what we usually did there. We actually were 3 people to do, I think, a course of 15 or 20 there. that we have experienced. So we know exactly what to travel with and what to do. But the in-person meetings are the best. To do it online, you can't touch a person's camera and see what he's doing wrong and edit the photos. So it just doesn't work. It must be an in-person type of situation.
And would you be available to do that in the US?
Yeah, I think we can talk about it.
All right, we'll
We
get
can
back
always
and
also try and talk to. We were on our way to Charlotte to present this course at Dentsply there as well, and that
Yes.
was actually planned for 2020. It was already planned, and then COVID hit, so we cancelled that. But we can always talk to them and go back, and we can maybe share costs between the two venues as well.
Charlotte is just up the road. So
Yeah, so
yeah, all right,
that's
I'll
very
get back with you and we can go into detail.
Cool.
And potentially Steve Reimer might be, especially his son, who actually teaches a lot of photography, who may be available. All right,
Okay, cool.
having said that, anyone got any questions or input or curiosity about that? But I'm just overwhelmed. Bobby.
Couple things. First of all, outstanding. The documentation and
That's
I mean, I've been
amazing.
trying to hammer into my students' heads ergonomics forever. And what they don't understand is that one of the oral surgeons I teach with had to retire at the age of 40 because of spinal injuries to his neck. So I actually took a few of those photos, and I always give credit. It's never my own work when I show someone else's, but so that's number one. Number two, on Colin's question, I think personally, I would rather do it up the road from you and do the photo workshop in Botswana. Having
That's
been
also
on
a good idea.
Kenya, Tanzania, and South Africa twice, I'd rather go to Botswana, which I haven't gone to. So I
Yeah,
think
that's a
that
good
might be
idea.
an even more interesting choice. And
Because
last
then
thing,
we can do, sorry to interrupt you, then we can do two things. We can do dental photography and we can do wildlife photography.
that is my goal. And I'll bring all my Canon stuff along.
Okay, cool.
So on the last case there, I do a lot of work with one of the companies that sells an amnion chorion membrane. And they have been doing some work for the last few years in the endo arena about putting it in teeth that have pulpal exposures and seeing interesting clinical and histologic results. I just don't know if you've tried that as compared to platelet-rich fibrin.
To be honest, most of my revascularization cases I just do with placing calcium hydroxide or tri-paste antibiotics, go back, stimulate bleeding, and pack MTA on there. That's what I usually do. We started doing PRF. It's not a normal thing we did. In this case, I was quite disappointed that it didn't work, but I think it was just a vertical root fracture. We've got about 3 other cases that it did work, but that's where my experience stopped in that. But I'd like to know what the product is and investigate that.
Do you know if the Snoasis product BioExclude is available in South Africa?
But no idea. I don't think so. I've never heard about it.
Okay,
not-
I will
it's
get
not, Bobby.
that doesn't mean we can't get it there. I will get your information from Colin and I will pass it along to the people I'm working with.
Super. I appreciate that. I would love to see that material.
It's so cool.
Thank you.
Andy,
Pete, it was a great presentation.
guys,
Um,
if you,
thank you.
sorry, 1 second. Guys, if you just open up your video so we can see all the people, it makes it a little more fun, a little more intimate. And Pete can see who he's been speaking with all morning. To
Thank
open
you.
up your video at this stage, make sure you're dressed. Okay, Andy.
It was great. I have a question about magnification. I teach in a hospital residency where we have a grad endo program. And I am always over there with Fred Barnett and Lou Walsman and Steve Nimzek looking at their scopes. And I tried the Zoomax, but what I found was that for restorative, it was really cumbersome to use because you have to work around different parts of the mouth. Is it reasonable to spend the time training? Because right now I'm using Zeiss loops to go that way. You know, because I'm not focused on one tooth. I'm all over the place. And that was the difficulty.
again, sorry, I just want to get your question. You said you use Zumax microscope?
I did, I tried it, and it was very cumbersome because I had to go all over the mouth. You know, when I'm looking at one area, looking at the occlusion, another spot, it was very time consuming. To try to use a microscope compared to 4.5 times loops in size. Is it worth the time learning it, and will it work?
I think the value you'll get at the end, it's worth it. As I said, the key thing here is rubber dam for me. For instance, if I prep crowns, I'll do split dam, and I'll prep 90% of my crown with the microscope. Then I'll take it off and I'll do my final marginalization. Sometimes I finish the whole prep, pack the cord, and even scan over rubber dam. So that's the key. If I take the rubber dam out of the equation, microscope magnification in the restorative dentistry will be a nightmare for me. Then I would rather use loops. Something that I would look at for that graduate program is that Brian dental loops that I've just explained to you, because there you can see detail on the tooth you're working on and surrounding tissues. It's really worthwhile looking. I don't know if there's a distributor in the US for that, but that loop system is changing the way I'm starting to think about even my microscope. It's really amazing to see so much detail. The other thing I didn't speak about, the transition between where the light, the visual area that you see is usually sharp with loops. This transitions out like soft.
Okay.
It's so nice on your eyes. So for a postgrad program for restorative dentistry, and I know you guys probably work on multiple teeth. I'm working mostly, in all fairness, on single teeth, 1 or 2 teeth maybe. So then it works with the microscope. If you prep an arch, I'm going to agree with you, the microscope is going to become cumbersome.
Yeah.
Then I would rather look at that Brian dental stuff that you can see a full view of the arch.
Oh, great.
That's
Thank you.
what I would look at.
Peter, I think he was also talking about Andy's a full mouth prosthodontist, and it could be preparing multiple teeth across the arch in one big long session.
That's where that
and the best
3.5 times or 3.8 times loops from Brian Dental is amazing. You can't believe when you look through it the first time how much you can see on the peripheral side. That blew my mind, because usually you see just the focus area where you work on. Yeah, you can see soft tissue, you can see lip movement. It's really crazy. It's really a different world under magnification if you look at that loop system.
Great.
Okay. Two comments I want to make. Number one is, I am a victim of 40 years sitting in a figure S configuration, and the only thing I regret is I'd seen the programs, and we had for our study club a session on magnification, and I didn't do it. And today, many years later, I sincerely regret not having incorporated proper magnification when I had the resources to do it into daily practice. So cannot emphasize that enough as a victim with lower neck and upper back issues. That's number one. Number two, we just had last week, Bobby was there, some others might have been there, our annual Academy of Periodontology meeting. And I attended a session by an attorney who does dental malpractice. And his comment, and he's very well known in the United States and amongst dentists, his comment was photograph, 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 photograph. One of the expert witnesses he uses in building up his cases is an oral surgeon in Florida. He didn't mention names. And he said that that oral surgeon, for example, in his mitigating legal issues, can take up to 30 photographs per procedure that he's doing. No need to write anything. And I do that with our residents. Never put your camera away, never put your camera down, photograph, photograph, photograph. And then in a law of court, and one hates to speak like that, especially to a group like this, in a court of law, once you've got it all photographed and you've done, the standard of care, you are covered. So those two comments, magnification and photography is absolutely the issue. Any other questions, comments, inputs? All right, what I'm going to do now, and I'm not very good at this stuff, but my boss, Alan Farber, says, just let me stop sharing your screen, and I'm going to hopefully share my screen. And please, guys, tell me if you can see. Alan wanted me to show you the upcoming programs that we have for this month. So there they are. Can you see that with
Yes.
Frank Salenza? Can you guys see? Okay. So there you see November's programs. And here is, apparently you need to take a picture, fill out the survey, and you will then be getting your CE credits. I may as well do the same. And then we will thank everybody. Let me just do that as well. There we go. Touch it. Okay, and up comes your CE form. So having said that, Pete, I cannot thank you more than enough for another stunning program. You need to really be, and I know you have been, proud of what you've achieved, proud of your photography. In my humble opinion, for what it's worth, I've attended many of these sessions, and this is in another world, in another planet. So thank you for that. Thank you for so generously sharing with us. Thank you for your friendship. And I will be back to you to see if either through this group or a different group, we can set up an in-person session and have fun at that type of a meeting. So having said all that, guys, enjoy the rest of your weekend. Once again, go Georgia. It's a Georgia-Tennessee game. Whatever can I say? They're probably playing right now. But my passion is still rugby, and I've never really understood American football, except when my kids try and explain to me what's going on. My passion is still rugby. So having said all of that, enjoy. Pete, enjoy Saturday night where you are, and have a good sleep, and we'll speak soon.
Thank you to everyone. Thank you for your time. I've shared the article with Colin, so you can share it with you.
Yes.
And it was really nice spending time with you guys. Thank you.
Thank you
Pete.
again for an
Forward to the
outstanding
information, Bobby. Thank
presentation.
you.
Great.
Okay.
Take care, everybody.
Bye.
Bye-bye.